Well, ideally, it's best to treat early because preventing a disease is much better than trying to treat it. But there's still things that we can do for patients that come in later in their adolescence or in adulthood. So maybe we can talk about what are some of those things that we can do.
Well,
for
starting
them.
the primary dentition, it's obvious that expansion can be easily be done. Of course, we had the conversation about you cannot expand your way out of an anterior-posterior problem. That's where orthotropics comes in to try to develop everything forward as much as possible. So ideally, you would do that in the primary dentition, but so frequently we don't get there. We get people who are coming in, the lower front teeth, they're coming in, they're crowded. Well, that's just an indication of an overall problem. Usually there's an airway issue with that that's caused it. There's definitely an oral posture issue. So instead of taking out teeth, like I used to do back in the 1970s, baby teeth to make room, and actually making less room in the long run, you expand in the mixed dentition in the 6, 7, 8, 9, 10-year-old age group. Then past that time is really the time when sadly, most orthodontic referrals come in. You're seeing them, they've got most, if not all of their permanent teeth in. And also a lot of growth has gone, water under the bridge. That's never going to come back. You can still do things there, and you do the best you can at that given time. Of course, never doing anything to retract, but that's where we've gotten things where you can move the lower front teeth forward in patients who are like this. Instead of doing this, you can do that. And I've been doing that long enough to know that it's okay. And of course, I have my 7 articles in the referee literature that say you can advance the teeth forward without causing recession to support what I've learned over the last essentially 40 years. Going beyond that, there's also a lot of people who've slipped through the cracks, and maybe they've had traditional orthodontics, and maybe they've had teeth taken out. Maybe they've been retracted back. Maybe they've worn a headgear, which retarded the forward growth of the upper jaw and made the lower jaw grow down and back. Sadly, this happens. There are things we can do for them. Many of them will be amenable to reopening previous orthodontic extraction spaces. Some may be where they didn't have teeth taken out, you could add teeth that have been where they weren't taken out. There's something to do for any given person. You just have to be creative about it. And then there's that group, which I politely term the train wreck patients, who have often been seeking treatment for 10, 20 or more years and have spent unconscionable sums of money, seen literally, no joke, hundreds of doctors. And they finally come to us, and we recognize there's an airway problem that no one else ever talked about.